Welcome back to the deep dive. Today we're unpacking a really fascinating 10-year surgical retrospective. Kind of changes the conversation about global healthcare scalability, I think.
It really does.
We're diving into research from Lagos, Nigeria that confirms, yes, high-risk metabolic surgeries can be done safely by a specialist team, but, and this is the twist, it reveals the biggest danger wasn't necessarily the surgery itself. It was the infrastructure, supporting the operating room.
That's such a critical point, and it really gets to the heart of this deep dive. We know, globally, metabolic and bariatric surgery, MBS, it's proven effective against severe obesity.
Yeah.
Hugely effective.
Yeah.
But look at the map. Look at the research, the centers. There's this massive geographical inequality. And our sources today, they tackle a really glaring hole in that data. West Africa.
So we're looking at a single but really important retrospective review. It covers 381 consecutive patients, all treated by one surgical team in Lagos.
Yeah, between January 2012 and mid-2022, so a full decade.
10 years.
And the mission of the source material here is just vital. It's about understanding the specific demographics, the challenges, the outcomes of delivering these advanced surgical services in this environment.
Just so different.
Exactly.
Yeah.
And you need to get the context. North Africa, thousands of procedures, loads of research every year. But West Africa, there's what the paper calls a palpable absence of similar studies, just not much out there. So this paper, it's really a landmark effort trying to close that data gap.
Okay, so let's unpack the why. Why is the need for these services just escalating so rapidly in Nigeria?
Well, it's tied into this rapid nutrition transition. Urbanization is a big driver. For years, the focus was all infectious disease.
Right, understandably.
But now, obesity is accelerating, is becoming a major public health hazard. The prevalence of overweight adults in Nigeria is estimated around 27.6%.
Okay.
And full-blown obesity, about 14.5%. And the source really points to this westernization of our pattern of living.
The usual suspects.
Pretty much. More energy-dense processed foods, less physical activity.
Yeah.
It's the urbanization effect.
So, okay, that's the backdrop, the rising tide. Who were these 381 individuals who actually, took that significant step to get treatment? Well, the mean age was fairly young, actually, 41.4 years on average. But the gender split, that's one of the most striking features of the study. Females made up a huge 82.4% of the group.
82%. Wow.
Yeah, 314 patients were women.
That's just astounding, because we know that's quite different from trends in, say, the U.S. or Europe, where it's often closer to 50-50, or even skewed the other way sometimes.
Exactly.
Does the source give any clues? Why are women in sub-Saharan Africa apparently disproportionately affected by severe obesity and the ones seeking this kind of treatment?
It doesn't dive super deep into the why in this paper, but it does confirm it aligns with existing data showing this high prevalence of female obesity in the region. It's likely, a complex mix, socioeconomic factors, maybe cultural norms around body image, access to exercise, diet control. It's multifaceted.
Yeah. But the bottom line is, for whatever reasons, it is overwhelmingly women presenting to the specialist center asking for help.
And these patients, they weren't just mildly overweight. They were dealing with severe disease, right?
Absolutely. Their mean body mass index, the BMI, at presentation was very high, 42.4.
Okay.
And get this, more than half, 56%, were class 3 obese. That's BMI over 40. The highest risk category.
So really significant health risks involved.
Definitely. And the comorbidities reflect that. Hypertension was the most common, found in 26% of patients, type 2 diabetes in about 8.7%. The link between this level of obesity and metabolic disease is just crystal clear in this cohort.
Okay, let's shift to the treatments then. Across that decade, what do they actually do? The mix of interventions tells a story, doesn't it?
It really does. It speaks volumes about sort of community trust and maybe patient anxiety levels early on.
How so?
Well, when they started, the unit leaned heavily on the non-operative option, the intragastric balloon. That accounted for 57.7% of all cases over the decade.
So over half.
Yeah, 220 patients. Then you have the main operative procedures, laparoscopic sleeve gastrectomy, or LSG. That was 41.3%, so 157 cases.
Okay, getting close to the balloon numbers over time.
Exactly. And then the laparoscopic one anastomosis gastric bypass, the OAGB, that was only done 4 times, just 1%.
And the source mentions this slow but convincing acceptance. I mean, when you see that kind of shift, patients moving from mostly wanting balloons to being more open to complex surgeries like the sleeve, That feels like more than just data.
Oh, it is.
It feels like they cleared a major hurdle, maybe overcoming fear or skepticism.
That's spot on. The team themselves noted this. As patient success stories started getting out there, maybe word of mouth, maybe social media,
Right.
the anxiety on the actual surgery started to lessen,
Hmm.
and the data confirms it. Over the 10 years, you see this consistent relative increase in the operative procedures of sleep, basically compared to the balloon. Trust was building.
Okay, so trust builds, more people opt for surgery. Let's talk about efficacy. How much better were the outcomes for the surgical group? Was it worth overcoming that anxiety?
Oh, the difference is quite striking. After 1 year, looking at the mean weight loss, the balloon patients lost an average of 16.0 kilograms.
16. Okay.
The sleeve gastrectomy group, they lost an average of 28.7 kilograms.
Wow, okay, that's nearly double.
Almost double the weight loss. It's a huge difference in impact.
That really underlines the power of the surgical option.
It does. But we also need to remember the starting point. This is important. The patients who chose the sleeve, they actually started with a statistically significantly higher disease burden.
Oh, okay.
Their average starting weight was 128 kilograms, BMI of 44.8. The balloon patient started, on average, at 116.2 kilos, BMI 40.1.
So the patients who needed it most were getting the most effective treatment.
Exactly. This is just good patient selection, steering those with the most severe obesity towards the more definitive surgical solution.
Right. Now, let's get to the safety profile, because doing this kind of surgery safely in any setting is key, but especially here. The study's big finding is that these services can be delivered safely by a well-trained team in this population. That's huge news.
It's arguably the most important finding. It's the ultimate endorsement of their clinical skill, really. Looking at the balloon group first, the non-operative one, complications occurred in 8 patients, so a rate of 3.6%.
Pretty low.
Very low, and only 1 was considered a major specific complication. A patient had a small tear during the balloon insertion. It needed immediate surgical repair, but the patient did well, discharged quickly, no long-term issues. So 0.4% major complication rate there.
Okay, managed well. And what about the surgeries, the sleeve and the few bypasses?
The surgical complication rate was remarkably low too, actually, just 2.5%. That involved 4 serious complications in total across the 161 surgical patients.
And the source points out that 2.5% is actually lower than some other reports from the region.
Yes, it does.
Hmm.
Some regional studies have reported rates as high as 8%. So 2.5% looks very good comparatively.
What were those complications?
2 patients had postoperative bleeding from the staple line, required going back to the OR urgently for a washout.
Okay.
And 2 patients developed peritoneal sepsis, basically, an infection inside the abdomen due to a leak from the staple line. Both presented within about 12 days. Required complex management, repeat surgery, drainage, and in one case, even a temporary stent.
So serious issues, but managed.
Managed, yes. But then we have to address the single mortality reported in the study. It's crucial to understand the specifics here as it relates back to that infrastructure point we started with.
Right. What happened?
This is where it gets really telling. There was 1 death within 30 days of surgery following a lap sleeve gastrectomy. That's a 0.6% mortality rate for the surgical group.
Okay.
But crucially, the source material is very clear. The death happened because of multi-organ failure, which was secondary to an early hemolytic blood transfusion reaction.
Wait, so let me make sure I understand. The surgery itself, the sleeve, was technically okay. The initial complication was bleeding, which they managed.
Correct.
But the patient died because the blood they received during the resuscitation caused a fatal reaction.
Precisely. It wasn't a failure of the surgeon's technique in the OR. It was a devastating failure in a critical support system, the safety and compatibility testing of the blood bank supply.
Wow.
That single tragic event just perfectly highlights the link between the success of the highly skilled clinical team and the potential limitations imposed by the surrounding infrastructure.
That really drives the point home. Okay, looking beyond the clinical specifics, what about the broader impact of this unit over its 10 years in Lagos?
Well, a core goal was just to provide a credible local option. Anecdotally, many Nigerian patients still travel overseas for obesity treatment, medical tourism.
Right.
So providing this high-quality, evidence-based care locally is a massive win. It stops that drain potential.
And it seems like it gained acceptance within the local medical community, too.
Yes, absolutely. The study notes that its presence is helping build acceptance, not just in the community, but among other doctors, cardiologists, endocrinologists. They're now more comfortable referring patients for surgery.
That collaboration is key.
It is. And this single study, it represents the largest group of patients, the most detailed outcomes published from this region so far, It sets a benchmark.
That's a tremendous achievement for one team over a decade. So just to sum up, this deep dive really confirms that specialized metabolic surgery is feasible and can be safe in Lagos, Nigeria. The results are good, complication rates are competitive internationally.
Definitely. And the patient profile is unique. That very high female representation, the high rate of class 3 obesity, it gives us real-world data.
But if we connect this back to the bigger picture, the team showed clinical excellence, no doubt. But the source material concludes with this really important thought about the future. It stresses that, okay, clinical skill is vital, but growing these services across the region, that needs heavy, deep investment in minimum standard infrastructure.
That's the crucial qualifier.
Which brings us to the final question, really for you, the listener, and for policymakers. In places where resources are tight, how do you balance this? You've got proven clinical success from a top team.
Right.
But you need that solid infrastructure like flawless blood banking, reliable post-op monitoring to support safe growth everywhere, not just in one specialist center. How do you scale safely and avoid future problems linked to those system weaknesses?
It's the fundamental challenge, isn't it? Scaling quality without sacrificing safety when resources are limited. Something we definitely all need to think about as we consider the future of health equity globally.
A very important question indeed. That feels like the right place to leave it. Thank you for joining us for this deep dive.